So today's topic is functional limitation G codes and PQRS. This webinar is specifically for physical therapists. We're not going to be talking about chiropractic or medical services at all today. This is specifically for physical therapy services. Again, not chiropractic, not medical. This is specifically for physical therapy services. So, the functional limitation G codes. Why is Medicare doing this? This is a Medicare requirement. As part of the Middle Class Tax Relief Act of 2012, CMS committed to collect data on patient functional limitations. So this is a 5-year project. This is the reporting of functional limitation G codes through the use of G codes, functional limitations through the use of G codes. Now this began January 1st, 2013. So there was a testing period of January 1st, 2013 through June 30th of 2013. So as of July 1st, 2013, claims submitted without the appropriate G codes and modifiers are going to get returned unpaid. So this is a very important process and requirement that Medicare is now requiring. This is not for Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, State Farm, Allstate. This is specifically for outpatient physical therapy services when provided to Medicare patients. So this is a data collection effort. Medicare figured, you know what, the only way we're going to be able to gather this data is through claim submission. They don't want you to send in your notes. They're not going to ask the patient about what's going on, so they felt the best way to collect this data is through claim submission. So these G codes and the modifiers, which we're going to get into very specifically in a few minutes, must be present in the documentation and on the claim forms. The documentation is supposed to show what tools and other information led to the values being submitted on the claim. So the tools I'm going to go over also in a few minutes. So the functional limitation guidelines were selected by CMS from the International Classification of Functioning Disability and Health. It's the ICF. Most physical therapists and chiropractors and medical doctors that I speak to have never heard of this organization. So all practice settings that provide outpatient therapy must include this information on the claim. This applies to physical therapy, which we're going to be focusing on here. Also occupational therapy, speech-language pathology, rehabilitation agencies, non-physician practitioners providing physical therapy services. So the functional G codes and the corresponding severity modifiers are used in the required reporting on specified therapy claims for certain dates of service. So reporting requirements apply to all therapy claims above the therapy cap and even the services with the KX modifier. These requirements also apply to Incident to services if a physical therapist was providing the services incident to an MD. They still apply. So these G codes identify the type of functional limitation and the current status, the goal status, and the discharge status of the patient. So functional reporting is required on the claims, at the outset of the therapy episode, at least once every 10 treatment days, the same date of service that an evaluation is submitted, like a 97001 or 97002, at the time of discharge, and on the same date of service, the reporting of a particular limitation is ended in cases where the need for further therapy is needed. So the projected goal for the functional status at the end of the treatment will be reported on the first claim and at the end of the episode. Modifiers will indicate the extent of the severity/complexity of the functional limitation. Now only one functional limitation could be given at each time, because some patients come in with 2 or 3 functional limitations, but you only have to pick one. You must pick one, actually. If the patient has more than one, report the one that is based on the most clinically relevant, the one that will yield the fastest return to functional progress, or the one that has the priority for the patient. So the 4 key functional limitation measures There are 4 that must be measured, documented, and billed using the G codes and modifiers. Number 1, walking and moving around. Number 2, changing, maintaining body position. Number 3, carrying, moving, and handling objects. Number 4, self-care. So those are the 4 key measures that you must become aware of. So let's talk about walking and moving around. Here's the first G code that you need to become very familiar with. G8978, walking and moving around, functional limitation, current status, at episode and reporting intervals. Next, G8979, walking and moving around, projected goal. G8980, walking and moving around, at discharge. So these are the key items that you need to discuss in your notes regarding walking and moving around. So we're talking about walking along a surface on foot, step by step, so that one foot is always on the ground, such when strolling, walking forwards or backwards or sideways, walking short or long distances, walking on different surfaces. These are the things you have to ascertain from the patient. Asking the patient about walking for less than 1 kilometer, that's a short distance, such as walking around a room, walking within a building. Asking the patient about how do they feel when they walk long distances for more than 1 kilometer. Kilometer is about 6/10 of a mile, such as walking around a town or in open areas. Asking the patient about how does their problem affect when they walk on different surfaces, uneven surfaces, such as grass, gravel, or walking around on a cruise ship, a train. Walking around obstacles, you should ask the patient. Moving around immobile objects. Walking around the marketplace. Shopping. Walking through traffic around crowded areas. Walking or moving your body from one place to another, such as climbing. Running down a street. Now, a typical Medicare patient, I don't see running down the street or rock climbing or jumping or somersaulting, but again, these are the things that you need to ask, such as crawling, climbing, running, jumping, swimming, moving around in different locations, moving around within the home, walking around in one's home, within a room, between rooms, walking from the floor to floor or an attached balcony, a courtyard, a porch, moving around the outside of the home, walking around without the use of public transportation. So those are some of the recommended things to discuss regarding walking and moving around. Next, changing and maintaining body position. This is the second function. Here are the 3 G codes associated. Each one of these has 3 G codes. Changing in body position, the current status is G8981. Change in maintaining body position at the projected goal is G8982. Changing, maintaining body position at discharge is G8983. So what is this? These are the questions you should be asking your patients when it comes to functional limitations. Asking, or they could be filling out forms, which we're going to get to in a few minutes. So basic body positions, getting in and out of a body position, moving from one location to another, getting up out of a chair to lie down on a bed, getting in and out of the squatting or kneeling position. Includes body positions from lying down, squatting to kneeling, sitting to standing, bending and shifting. See that? Lying down, squatting, kneeling, all of these things you should be documenting. So as far as sitting, getting into and out of a seated position and changing body position. This also includes sitting in a position with the legs bent or cross-legged. When it comes to standing, getting in and out of a standing position or changing body position from standing to another position. How about bending, tilting backwards or from side to side, or tilting the torso in such as, reaching down to lift an object. Shifting the body's center of gravity. Maintaining body position, staying in the same body position as required. So you have to remain standing at work or at school. Maintaining lying, squatting, kneeling, face down or face up. Maintaining a squatting position. Again, you need to get this information from the patient. Either they have to fill out forms, or you have to ask questions and document it, or maybe you have some specialized physical therapy software where you can click and point and get all this information in. Maintaining a standing position. This includes standing in a position on a slope or a slippery or hard surface, transferring oneself. This also includes moving from chair to another seat. Patients could come in a wheelchair, moving from a wheelchair to a car seat, transferring oneself while lying, moving from one lying position to another on the same or a different level, such as moving from one bed to another bed. Next functional measure is carrying, moving, and handling objects. So now we have 3 more G codes. G8934 at the current episode, G8985 at the goal, and G8986 at discharge. So what does this involve? Lifting and carrying objects, raising an object or taking something from one place to another, lifting a cup or carrying a child from one room to another, carrying objects in your hands or on your shoulders or on your hip, putting things down, lifting, raising up an object in order to move it from a lower to a higher position. Example would be lifting a glass from the table. Carrying things in your hands, taking or transporting an object from one place to another, carrying items in your arms, using your arms, such as, carrying a child. A Medicare patient can come in and say, I have difficulty lifting my grandchild off the floor. Carrying on your shoulders, hips, taking or transporting an object from one place to another, such as carrying a large package. Putting down objects, using your arms or hands to place an object from a surface or a place, such as lowering a container of water to the ground. Performing coordinated actions aimed at using the legs and feet, such as kicking a ball, riding a bicycle. Again, Medicare patients, how many of them are kicking a ball? But you need to be aware of these things and question the patient. Pushing up with the lower extremities, using the legs or feet to exert force, about pushing a chair away with your foot, kicking, find hand use, lift coins off a table. Patient might say, I have numbness and tingling from my neck down my arm, and I can't lift coins off a table or turn a doorknob. Picking things up, small objects like picking up a pencil off the table, grasping a doorknob or a tool, using your fingers, releasing an item of clothing, pushing, pulling, reaching, twisting, moving the arms, using utensils, throwing a ball, catching a ball. Next is self-care. This is huge. Here are the 3 codes, G8987, self-care functional limitation at the outset, beginning, current episode. G8988, projected goal, functional limitation with self-care. G8989 is self-care functional limitation at discharge. So what does this entail? Washing oneself, drying oneself, washing body parts, washing the whole body, drying oneself, using a towel, caring for body parts, taking care of your skin, nails, teeth. Some people say, you know what, I like to apply moisturizing lotion on my hands. I can't do it. Brushing teeth, flossing teeth, taking care of dental prostheses, caring for your hair, combing, styling, shaving, trimming, polishing nails, caring for toenails, trimming, cleaning toenails. For many Medicare patients, they can't do it. They have a functional limitation. toileting, cleaning oneself after using the toilet, menstrual care, dressing, putting on, taking off clothes, footwear, putting on clothes such as, putting your clothes over your head, putting on gloves and headgear, taking off clothes, putting on footwear, taking off footwear, eating, cutting food into pieces, opening bottles of cans, drinking, taking a hold of a drink, bringing it to the mouth. Is there a problem with that? Could be. That's how you're going to report these G codes. Ensuring one's comfort, managing diet and fitness, maintaining one's health. So those are the self-care examples. Now, there are other functional limitation codes. Now, you're going to use these when the patient's problem doesn't fit into any of the previous codes that I went to. I think it's rare, but if that happens, you'd have to use these. G8990, G8991, G8992, G8993, G8994, and G8995. Again, if the patient's functional limitation did not fit into any of the things that we went through in those four major categories. Now, the tools you're going to use, these are the best tools. For the neck, the gold standard, in my opinion, is the neck disability. Lower back, Oswestry, and Roland Morris. The upper extremity, I like the DASH form, which is the disability of the arm, shoulder, and hand. And then the LEFS, the lower extremity functional scale. This is a questionnaire containing 20 questions about the patient's ability to perform everyday tasks. Very important if you're going to be using tools. This is one of the best ways to measure patients' functional limitations. Then we have to use these severity/complexity modifiers. For each non-payable G code, a modifier must be used to report the severity complexity of that functional measure. The severity modifiers reflect the patient's percentage of functional impairment as determined by the therapist furnishing the therapy services. So CH, 0 impairment. CI, 1 to 20%. CJ, 20 to 40. CK, 40 to 60. CL, 60 to 80. CM, 80 to 100. CN, 100% impaired. So you're going to use the modifier that reflects the score from a measurement tool, like the outcome assessment form, or some from other functional evaluation. You could use other evaluations besides outcome measurement forms. You could use range of motion, pain scales, reflexes, palpation, gait tests, muscle strength, muscle tone, muscle spasm, muscle weakness, sensory tests, orientation to time and place. Physical therapist must use his or her clinical judgment to combine the results of all these tests and measurements and determine the appropriate percentage of impairment. So an example, a 30% impairment is what? That's the CJ modifier. The documentation must support the level of impairment and the modifier chosen. Now, just a quick reminder, Medicare modifier GP is for PT services, GO is for OT services, GN is for speech-language pathology. So let me give you an example. Let's say a 68-year-old male presents to the office with low back pain and balance problems. He has difficulty walking and moving around and has a loss of balance after walking short distances. After standing for 15 minutes, the pain increases and causes the patient to have to sit down. The pain scale is an 8 out of 10. Outcome measurement score is 50% impairment. You have lumbar spasm, decreased lumbar range of motion, and antalgic lean. The goal is to reduce pain to 10% at the conclusion of care. So, how are you going to build this? Well, you're going to build your new patient evaluation, 97001. Let's say you do neuromuscular reeducation. That's 97002. Ultrasound. Okay, ultrasound, throw that in, 97035. Remember, these all get the GP modifier. And now which functional limitation G code are you going to use? Well, for walking and moving around, current status, that's G8978. With a 50% impairment, that's the CK modifier. So it would be G8978, CK, GP. You have to use two. The other one is the projected goal. So that would be G8979 CI, because the projected goal is at 10%, so that's CI, GP. Now let's go to the 10th visit. Patient is improving. He has less difficulty walking around short distances. After standing for 15 minutes, the pain does not cause the patient to have to sit down. Pain scale is a 5 out of 10. Outcome measurement score is 20% impairment. Lumbar spasm has decreased. Goal is to reduce the pain to 10%. So we have the reevaluation, for example, 97002. We're going to do the NMR again. We're going to do manual therapy this time. Again, all the GP modifiers. So what functional limitation G code are we going to use now? With a 25% impairment for the current status is G8978, CJ with the GP modifier. Walking and moving around, projected goal, G8979, CI. That was the same as the first visit. That's okay. It's okay to have the same projected goal on the 10th visit as the first visit. And then let me give you a sample discharge visit. Patient has improved significantly. Patient can now walk long distances without pain. The pain scale is a 2. Outcome measurement is 10%. Decreased lumbar range of motion, 10% impairment at discharge. So, what functional limitation codes are we going to use on this visit? G8979 for the projected goal with the CI modifier because there's a 10% impairment. And at discharge, that's G8980 with also a 10% impairment. So that's the CI modifier. A couple other things you should be aware of. You may be getting these remark codes, reason codes, remittance codes. 246, this is non-payable because it means that you had a bill a dollar amount because some software programs won't accept a $0 amount. These G codes, there's no charge. You should be putting $0. But some software programs don't accept it, so you have to put in 1 penny. You can't collect that from the patient. That's why you might get that 246 remittance. We have 565. This is non-payable. 566, procedure requires functional reporting. So you may see these on your Medicare EOBs. And here's your references that you should be checking out. It's the Medicare Internet-Only Manual, Outpatient Services, Publication 100-2. This is the Medicare Benefit Policy Manual, Chapter 15, Sections 220 to 230.6. You must check that out if you're going to be reporting these codes. The other one is Publication 100-4, Part B, Outpatient Rehab and CORF Services, Sections 10.2 to 10.7. Please check those out. Now I'll give you a quick PQRS update specifically for physical therapists, not chiropractors. So PQRS stands for Physician Quality Reporting System. The goal of the program is to improve the quality of care through quality measures. Remember, this is measurement. This is different than functional limitation. Reporting program that uses incentive and adjusted payments to promote reporting quality information by eligible professionals. Eligible professionals include PTs, chiropractors, medical doctors with NPI numbers. CMS create a list of 326 performance measures. You can check them out at cms.gov/PQRS. Successful participation requires reporting on at least 3 measures. Chiropractors only have to do 2. Physical therapists should be doing 3. So successful reporting this year is going to give you a little bonus in 2014. Also, if you report properly in this year, you'll be left alone. You'll avoid the 1.5% payment penalty. So the top 5 measures by PTs include Measure 131, which is the pain assessment, Measure 154 for falls and risk management, Measure 130, the documentation and verification of current medications in the record, Measure 155, falls for the plan of care, Measure 128, preventive care and screening. This is for a BMI screening and follow-up. So let me give you an example here of how to use PQRS. Let's say a brand new Medicare patient walks in. That's 97001 GP. And you also do manual therapy, 97140 GP. And you also calculated BMI, which was within normal parameters and documented. That's G8420. Eligible professionals attesting to document the patient's current medications is G8427. G8427. And pain assessment, utilizing a standard tool, with follow-up documented is G8730. And that could be as simple as, "Hi, Mrs. Jones, how are you doing today? On a scale of 1 to 10, what's your pain?" 10 is the worst, 1 is very mild. Patient says 7. You write that down. That qualifies for PQRS code G8730. So this was a quick overview. This was a lot of information that I provided you in the last 35 or 40 minutes. Hopefully you got it. If you have any questions, send them in. Just a few closing comments. We offer something called our Smart Choice program. It'll help you swan. What's that? What's swan? Swan means sleep well at night. Because we're about prevention. We want to make sure you're preventing fraud and audits. We want to show you how to strategically bill Blue Cross Blue Shield, Aetna, Cigna, United Healthcare. You should be collecting cash for many products and services. You should make sure you're not underbilling. If you're smart, you know how to code to the highest level of specificity. If you're smart, you know how to prevent dual fee schedules. If you're smart, you have trained staff members to help you maximize revenue. If you're smart, you know when not to use modifiers 5.2 and 5.9, and you know how to build time codes properly. So consider our Smart Choice program. It'll help you swan, sleep well at night. All you need to do is go to targetcoding.com and click on the services page. So you must check with all the carriers you bill prior to submitting claims based on the information provided in this presentation to ensure that it is compliant. Target coding does not guarantee that the information provided in this presentation will guarantee payment from any insurance carrier or patient. Target Coding and Discount Medical Supplies is not responsible for any insurance carrier or managed care organization laws, rules, and guidelines that may change following this presentation. So please understand that insurance carrier rules, laws, and guidelines and regulations change, right? They change all the time. So it's important to do your best to stay on top of these changes by attending seminars, fantastic webinars like these that Discount Medical Supplies puts on, and by joining your national and state professional associations.